So thank you very much, Dr. Koh. Thanks to the organizers. And this is indeed a difficult talk and task that you gave me. That's not especially data-driven, but that's developed some concepts of challenges and needs that we do have as a clinician, and I'm a GI oncologist, seeing on a daily basis many patients and involved in a lot of clinical research projects and translation research projects, and having a lot of interaction with the radiologists as well as with some other clinicians and researchers. So this is a difficult task to develop some of the topics here. Yesterday night, several of you asked me where was Leuven. Just therefore, I put one slide in that for those who are not aware. Where is Leuven? Leuven is a small university city, 100,000 inhabitants, 55,000 students. The university is founded in 1425, and we are ranked for the 4th consecutive year, #1 at the Reuters ranking of innovation in Europe. On top of that, I don't have any conflict of interest with the beer, but we have the biggest beer brewery in the world, with 26% of the beer production worldwide is controlled out of Leuven. Having said that, the topic is different than beer, but the topic is on the need for clinicians and the need that we can transfer to you what we expect from imaging and what are the challenges especially. And it's obvious that we need to make further progress in imaging, cancer imaging, and radiology. The cancer incidence is high. There are still too many deaths of cancer worldwide in Europe. And we have seen a lot of progresses in all different aspects, in our knowledge, in our technical knowledge, on diagnostic tools, on therapeutic tools. We have made a lot of progress in the molecular unraveling of tumors. We've seen many new drugs, but the art and the challenge is to bring all that together and to bring that into clinical practice and to apply that for clinical practice. And another reason is why we need to work on that is that our patients, and we do it for our patients, but also society, who invests a lot of money and a lot of resources through all different channels, they want us to solve the cancer problem and to make progress. And if you're, for instance, patients who donate for research, 6 months later they come back, they want to do a second donation, but they ask, what progress have you done in this 3 or 6 months' time? And so we want to do progress, and we want to make progress, and therefore it's important. In this talk, I will go from the clinical point of view and just unravel with you and give you a couple of examples focused on GI cancer, which is my area of expertise, but I think you can translate that to many different other cancers. And just a couple of examples. If you look in metastatic colorectal cancer, 15 years ago, we had one drug, 5-FU. Today, we have a list of drugs, cytotoxics, and targeted agents, and also immuno-oncology agents, that are approved and used for the treatment of patients with metastatic cancer. So the list will be much longer in the near future. Some of the drugs in red will also come to the market, or probably come to the market in the future. So the challenge is then to select the patients for which treatment option, and also to evaluate the benefit of the different treatment options. And there comes a different, let's say, important aspects, which is the molecular unraveling of cancer. But on top of that, the diagnostic accuracy with molecular markers, but also with imaging, is coming in an interface, and that's becoming crucial in this setting if we want to make further progress, and if we want to use these different agents in the optimal scenario and optimal setting. And as clinicians, as clinical oncologists, we are working on algorithms, how to treat patients with different characteristics, how to treat patients in different lines of treatment, how to start with a certain treatment, how to select patients, how to determine the strategy, how to look for patients which will be treated with medical treatment, with chemotherapy, with targeted agents, but also with local regional treatments or with surgery in this setting. And that's crucial in this setting. And therefore, if you look at how we do that in clinical practice, what are the drivers for the treatment? And here the example of metastatic colorectal cancer and a slide from the ESMO consensus guidelines. The clinical presentation, the imaging, and the molecular biology are clearly important drivers in our clinical decision, what we do for and with the patients in this setting. Markers are crucial, and I will develop on that, and we have to integrate them also with the imaging and with progress in imaging there. And if you look just at molecular markers, AI is for sure also coming into the field of molecular biology, molecular oncology. If you look at the cellular targets for antitumoral agents, it's obvious that we have to develop to unravel these different pathways, cellular pathways, on the same way as we have to make maps of the metro in Tokyo or of the painting of Michelangelo in the Sixtine Chapel in Rome. And colorectal cancer is being developed and being divided. We know that colorectal cancer is not one disease. We are working on that. We have made clear progress on what we call the molecular subtypes, and we call them here the consensus molecular subtypes. Also, immuno-oncology subtypes are now being unraveled also. And the art is to integrate that, and the art will be to integrate this knowledge also with the imaging in this setting. And of course, these markers are crucial, and that's in this setting. And we are not yet able to unravel all the different pathways that were on one of my previous slides. But we are tackling now some of the, let's say, driver mutations, some of the driver pathways, as for instance, this pathway, the EGFR, RAS, BRAF pathway. So we're working on single genes, single pathways. But in the future, we will, with the help of AI, also unravel the different pathways, as you will have to do, and together with the clinicians, on unraveling AI patterns in imaging for patients with cancer. And if we go further, and I will almost stop on molecular markers before then coming to some challenges really for the imaging and some expectations for the clinician of imaging. If we just further go on colorectal cancer, the unraveling of different genomic markers, the pie chart of colorectal cancer is going that way. In clinical practice, today, we do more and more, not in all patients, but more and more next-generation sequencing, completely unraveling of the markers. That's not done uniformly worldwide yet, but that will come. And in the US, every patient, almost every patient, at least in a big cancer center, gets an NGS panel. In Europe, also in the expert centers, more and more. But even that, we need, if they don't get a complete NGS panel, we need at least to have some molecular markers which are the basis of our treatment decisions. For instance, RAS, BRAF, we know that, for instance, for some of the targeted agents, if there is no RAS mutation, there may be a benefit of the EGFR antibodies. If there is a RAS mutation, there is no benefit in this. So the hype today for patients is to go for NGS, to go for liquid biopsies, through high throughput techniques where AI is being used more and more. And this brings us to the imaging also in this setting. Imaging is at least as crucial, at least as pivotal as all the knowledge, the molecular knowledge of our tumors and our patients in this setting. And if we look and if we try to analyze some of the aspects in this regard, where the radiological evaluation is crucial, I don't have to convince you, but I'll take you through some of the examples where we as a clinician see some challenges, where we see some possibilities to further improve the treatment and the outcome of our patients. We have made enormous progress in the diagnosis of tumors, in the detection of metastasis. We are not perfect with radiology, but progress is being made also in these different aspects: the diagnosis, the local staging, the detection of metastasis, the detection of the recurrence, and then more recently also in the evaluation of response on a treatment. And I'll develop some of these different aspects with through some examples, and through highlighting also some fields where a clinician, GI oncologist like myself, and a radiologist, where we have a daily interactions in the clinical and radiological evaluation, interpretation, and judgment of images. And sometimes today, that's what patients want also. The radiologist comes at our outpatient clinics, judges the images together with us on top of the tumor boards. And occasionally there are radiologists that I can convince to come to the patient to show to the patients also some of the evolution, some of the response, some of the lesions that are difficult to judge and that drive our clinical decisions in this setting. The daily interactions are clearly also there, and I will develop that further on the evaluation of response. I will not develop further on interventional radiology techniques, and it's obvious that progress can only be made through innovation and research projects. Let's list on 2 slides some of the unmet needs and challenges, and then dig into that further. We are making progress in the local staging. It's obvious, I don't have to convince you. You're all better experts than myself on that, but we are not perfect yet. And you know that for some of the GI cancers, for instance, of the patients that I do see, the local staging of rectal cancer, we have made some progress, for instance, with MRI, or in pancreatic cancer, or in esophageal cancer, but we are far from perfect on determining in an accurate way the T-staging, predicting in an accurate way the T-staging and the N-staging, which drives often our clinical decisions and our therapeutic decisions. We have made progress in the characterization of liver lesions, of other lesions, peritoneal lesions, for instance, but we are not yet perfect, so further progress has to be made. And AI can for sure, I'm convinced of that, can help on that. The sensitivity of imaging is important in the detection of tumor localization, tumor deposits, peritoneal metastasis, which was not easy, which is not easy yet, but where, for instance, MRI has made contribution and helped us making progress in this setting. This, not only the sensitivity, but also the specificity of imaging and the accuracy of imaging. And then especially also in the evaluation of benefit of response. I will develop some concepts of that without going too much in detail. As far as I understood, this was more a conceptual talk here that I had to give here. And then also an unmet need is clearly to do better in the imaging regarding tumor heterogeneity. Tumors are clearly heterogeneous. We know that if we look at molecular characteristics of tumors, of metastasis, even in the same organ, there are nice studies in the New England Journal of Medicine of different tumor types with metastasis, different metastases in the liver, where the molecular characteristics of the different metastases was different. So the optimal scenario would be could be that radiology can contribute also in solving some of the issues of molecular heterogeneity and mixed responses, what we do see in clinical practice. And we see regularly patients that we treat with a chemotherapy or a targeted agent or an immuno-oncology, where we see clearly progression on one localization, progression of bone metastasis, regression of the liver metastasis. It would be optimal if radiology and AI could help us in characterizing this heterogeneity of tumors and in helping us to predict and understanding the mixed responses and understanding what we should do for these patients. Because if you see that dramatic responses, for instance, in the liver, but then new metastases on other places in the bone, for instance. We are faced with the challenge in clinical practice when the patient is in front of us, what should we do in this setting? I don't have to talk to you, I couldn't assist yesterday, but I'm sure that you developed also topics on quality and quality control of imaging. And we as clinicians, we expect that also that an enormous lot of work is done. Because as I tell always, an MRI is not an MRI. If you see sometimes MRIs, the quality is not always identical. And the expertise of the protocol, making protocols, and again, I don't have to convince you on that, is also crucial in this setting. The expertise goes back to some easy images. Pathognomonic images like the one you see here, for instance, net tumors of the small bowel with the pathognomonic images. But I can challenge you, if that's shown sometimes to some radiologists with less expertise, that this is not being recognized. Of course, we need biopsies, but it is a pathognomic image that is crucial. Better resolution is crucial because the challenge is always, if you want to go for local regional therapies, of course, is are we sure, if you go for local regional therapy, for instance, of a liver metastasis, are we sure that there are no other metastases? And therefore, increasing the sensitivity, having high resolution techniques, and better characterization, for instance, of small lung nodules is crucial in this setting. And therefore, we put the burden as clinicians, also on you as radiologists, and on the nuclear medicine physicians together in collaboration, because the PET-CT and PET-MRI, and I will come back to that, are important tools in this setting. This better characterization, this better sensitivity is important for us as clinicians in the preclinical planning of resection, for instance, of liver metastasis. You know that patients with resectable liver metastasis and that we can cure around 30 to 40% of these patients if we are sure that with imaging or with other techniques that there is no extrahepatic disease that we cannot detect. So this is important to develop tools where we can detect as good as possible other localizations, avoid unnecessary surgery, for instance. If peritoneal metastases are present, you could say a laparoscopy is not difficult. That's not difficult for a patient either, but that puts on resources. So we always want to avoid unnecessary surgery to detect with better, more sensitive imaging techniques, and their AI is crucial also, and the further improvement of radiology, nuclear medicine, and the integration of both is important in the detection, for instance, of occult peritoneal disease, which is in GI cancers or ovarian cancers, often a big clinical challenge in this setting. We're making progress with the diffusion, with the whole body diffusion-weighted imaging techniques that are really very helpful for us as a clinician in this setting. But that's still a big challenge in this setting, especially if lower quality examinations are being done in clinical practice with referred patients. Sometimes that's what you see, that then the accuracy of these techniques is far from perfect in this setting, and that sometimes unnecessary surgery is being done in these patients that could be avoided with the optimal integration of imaging, such as whole body diffusion-weighted MRIs, as we do in this setting. And that speaks for itself that let's say it like that, the area of hybrid imaging with PET-CT, PET-MRI is coming into the arena, and that we as clinicians expect a lot of also the newer techniques such as PET-MRI in order to solve some of these issues in this setting, and in order to answer some of our clinical questions that we do have. With that also, with this hybrid imaging, I think that for us as clinicians, we do, and personally also coming from Leuven, I do believe that radiochemistry and radiopharmacy is important. and that we have to integrate that more and more in this setting, that we have to look into better tracings, better tracers that we can use in adapted to different disease settings with PET-CT, gallium dotatate, for instance, that has replaced completely the ultrascan. But now also, like we are doing a research project in this setting with PET MRI in this setting for the neuroendocrine tumors in this situation, that may improve our clinical, or that may answer some of our clinical knowledge and our clinical questions that we do have for our patients. Detection with these radio tracers, with different tracers, detection of otherwise not detected small metastases, such as this example here, is important. And I'm convinced, and that's what we see already in clinical practice, that some of the newer techniques can help us in answering some of the questions and detecting some of the radio, as we call it, radio occult bone metastasis, for instance, in this setting. Another completely different example, and that goes then also and comes into the arena also of better diagnosis, but also response prediction, is just the example of rectal cancer that I want to develop. What do we need in patients with rectal cancer? For clinical practice, it's for sure crucial that we need an accurate local staging, T and N staging. But on top of that, in view of the rapidly evolving integration in clinical practice of watch and wait strategies, of chemoradiotherapy, and avoiding surgery and sparing the rectum, it is crucial that adequate response evaluation techniques enter into the arena, and adequate techniques that can help us to predict patients with a complete response. Because we cannot allow that in a young patient who goes for a watch and wait strategy in a rectal cancer with the chemoradiotherapy or a total neoadjuvant treatment, as we call that, that these patients will still have occult disease that we don't detect, and that they will have a regrowth later on. So we really want to be sure for the patients in whom we can to spare the rectum. Rectal cancer, the staging has made some progress. Diffusion-weighted MRI has improved, has helped us, not perfectly, but has helped us on detecting and determining pathologic lymph nodes, and has helped us on looking at an adequate end staging in this setting. MRI has entered in all clinical guidelines today, and I would say almost that it's mandatory that it's in all patients, every patient with rectal cancer, that he should undergo an MRI. It really, and I don't have to convince you, it really determines the prognosis, but it drives also clearly what we do for our patients with rectal cancer. But on top of that, as I mentioned already, the response evaluation, and that's a bigger challenge. The response evaluation is extremely difficult for patients with rectal cancer in that setting. But we need further to work on that. We are making progress on that. And in the different protocols from different studies from Brazil, from Europe, in the strategy of watch and wait and organ-saving approach in rectal cancer, this response evaluation has been introduced, has made clear progress in this setting with an integrated, let's say, evaluation through clinical evaluation, endoscopic evaluation, MRI, and PET-CT in this setting. And through the integration of these different aspects, including clinical evaluation, we are able to predict in a much better way which patients will be on track for organ-saving strategy, with avoiding to remove the rectum with all the morbidity that goes together with the rectum resection in these patients. And that's going to be crucial. And I'm happy to see that there, over the last 2-3 years, we have learned an enormous lot, and we gathered an enormous lot of information in the clinical thinking, in the clinical setting for these patients. And the final topic I want to develop is some aspects on the response evaluation in metastatic disease. And that's another important aspect, crucial aspect, as I mentioned in the beginning. And that's why I showed you a list of different drugs that are in colorectal cancer, but we could do the list for many other cancers. Response evaluation is crucial. It's crucial in order to determine in clinical studies the efficacy of different agents, of different drugs, but also in order to determine in the clinical setting, once the drugs are available, to see which patients benefit more or which patients benefit from a certain drug, or when we should change the strategy for certain patients with metastatic disease. And classically, we were using the RECIST criteria, different versions of RECIST criteria. We are working with all different, and we are basing our the RECIST criteria and response evaluation and translating that in the evaluation of different agents. And here, for instance, the immuno-oncology agents, nivolumab and ipilimumab, in patients with microsatellite unstable metastatic colorectal cancer, and translating and transferring that if we don't have large numbers of patients that are being treated in the initial evaluation and the initial studies in molecular-driven subgroups. And like here, the MSI high colorectal cancer, MSI high colorectal cancer is responsible for approximately 4% of all colorectal cancer. So it's obvious that in the initial evaluation, we cannot do large studies with hundreds of patients looking at the survival. So we want to have other surrogate endpoints to see whether a drug in the initial evaluation is active. And therefore, we are trusting ourselves on far from perfect size criteria. That's what we do. And we translate that in waterfall plots, as we call it, or spaghetti plots on the top to see the duration of response, spaghetti plots here for this agent, and show that, for instance, here, this immuno-oncology agent, in many patients on the waterfall plots on the bottom, leads to a response. And in many patients who respond, leads to a long duration of response, as is shown in the spaghetti plots on top, coming from size evaluation from the imaging in this setting. And also even with new treatment options, with combination agents on the pathway that I've shown you on the EGFR pathway. For instance, in the BRAF mutant patients, BRAF V600 mutant colorectal cancers, 8% of colorectal cancers have a BRAF V600E mutation. It's now standard to look into that. They are aggressive, they have a very bad prognosis, and they are resistant to chemotherapy. So there is an unmet need in this setting. And that's why we need to understand that to have adequate tools to look in relatively small groups of patients, like here, this 30-patient study, to see with response evaluation criteria and to translate that in a waterfall plots, as we did recently, with this triplet combination of expensive targeted agents, BRAF inhibitor, MEK inhibitor, and EGFR inhibitor, to see whether these agents have hints of activity before we embark on larger phase 3 studies. So this is important. And even if we go further, in complex clinical studies with different groups, evaluation of response and of activity is important. And classically, we do that with size-based criteria, RECIST and modifications of RECIST. But as you all know, they are good for drugs with a more cytotoxic mechanism of action, but they are far from perfect for drugs with a more cytostatic mechanism of action. For instance, angiogenesis inhibitors, marker-targeted agents, immuno-oncology agents. There are drugs, if we use a size-based criteria, where we may miss the benefit of the drug in this situation. So therefore, we do expect that we can hopefully develop new tools, as you all know, that can help us as clinicians in order to determine clearly in a much better way how we can evaluate early on the activity of these different agents. And for instance, another example, this is a patient who was treated with an end-stage colorectal cancer with a TKI, a VEGFR TKI, so an angiogenesis inhibitor with many different small lung metastases, where you see the cavitation arising, and where you see also a change in the pattern. And initially, when we saw these first images, it's not always easy. Do you call this a progression? Do you call that a regression? In the clinical setting, the reality was that this patient had a major clinical benefit, a major drop in the tumor markers in this setting. So it shows clearly that with size-based evaluations, we are not there for these new agents, and that's going to be important. And so therefore, different criteria, such as the immune-related response criteria, are being developed in this setting. Functional MRI, PET-CT, PET-MRI is going to be important in this setting. And also in the early evaluation, for instance, this was a patient with radioembolization of liver metastasis with some benefit of the early evaluation in the FDG PET patient on the right side with no benefit, no decrease on FDG PET, with completely different long-term, completely different outcome and completely different survival. So the integration of these different aspects is important. And finally, even also with some of the new, let's say, tracers, with binding tracers on drugs, on cetuximab, on trastuzumab, on HER2 nanobodies, integrating that in imaging. There is still a lot of work to do, still a lot of progress to be made, but we see some, let's say, some news coming through that will help us as clinician, but not help us as clinician, but that will help the patient, especially in view of the bigger armamentarium, in the bigger use of different tools that we do have in this setting, bigger number of drugs. With bigger number of drugs, we need to understand better which drugs helps the patients and which drug helps not the patient. And then also, as I mentioned, solve the issue of tumor heterogeneity, as I mentioned already. So the future of imaging is clearly there. We need you all to work on imaging. We need to stop and think, and I'm sure if we can do that in a rational way, in a collaborative way with clinicians, in a collaboration also with people on experts in molecular oncology and molecular markers of patients with cancer, that we will make progress, and that it's all in the image and in the genes, as you can see on the image of my 4 women at home. Thank you very much.